Um, Good afternoon, everyone, and thank you for being here. We have a number of people in Savannah, and we also have a large number online in Zoom. If you are tying into this presentation by Zoom, you are muted. So if you wish to ask a question as we conclude, go to your chat room and put that question, and we'll monitor that. I'm really delighted to introduce you to three of our best and finest faculty. And I really appreciate the work this group has done to put this presentation together. I think it's needed. It's really hard to sort out in the media, and it's moving so fast, it's hard to interpret what we hear. So you have three experts here that will help us all be educated. Dr. Smitke is going to start off, Dr. Bentz will follow, and then Dr. Vasali in Savannah. Dr. Smitke is a microbiologist, Dr. Bentz is an immunologist, and Dr. Vasali is a virologist. Thank you.
Okay, so yes, I'm Dr. Smitke. Thank you very much for coming. Like she said, I know that there's a lot of information out there. It's changing very rapidly, but we've had some questions from our students about what is going on, and is there a central sort of piece of information that we can give them as they're getting questions from their parents and questions from each other about what's going on. And so I've always believed that people are afraid of what they don't understand. And if we can ease any of your anxiety, then the things will be less frightening. I will also say that I cannot guarantee that this won't frighten you, but I will be honest with you and you will have the most up-to-date information there is. But I think if we can approach everything rationally and calmly, then we'll all be better off. So I know there are a lot of big questions that exist out there that maybe you've heard, maybe you have. And there's a lot of information circulating out there. So we're going to talk about some of the big questions that I know Dr. Bentz and I have received, and kind of walk you through some of the logic behind why certain actions are being recommended or taken. We'll talk about the virus itself. We'll talk about why it's spreading the way that it is, and who we are most concerned about. So to start, and I know I should mention also that this presentation is meant for a wide range of people. There is some technical information in here, but we've tried to make most of it as public friendly as we possibly can, because we know that everybody's concerned and everybody has a stake in this. But I wanted to start with some terms and what they mean. So what you often hear signs and symptoms put together. Signs means things that a person can observe about you, whereas symptoms are going to be things that you can report based on your internal clock or sensation of what's going on with you. So a person can't tell that you have a headache. You can report that, that's a symptom, but it's not necessarily a sign. Your temperature is a sign. We also have variations of illness. We can have acute illnesses. We can have what's called subacute illnesses, where they're sick, but it doesn't really present as easy to identify as some of our more significant cases. And that's important because with COVID, we have a lot of subacute cases. So I wanted to make that distinction. The other key difference I wanted to bring up was the difference between a primary infection versus a secondary infection. We all know that influenza kills people every year. And honestly, sometimes the thing that's killing them isn't influenza itself, but a secondary infection that comes right on its heels, like a pneumonia sort of thing. And so that's one thing we're real worried about with the COVID situation, is that, of course, COVID is significant on its own for certain populations, and it leaves them more vulnerable for more significant infections. All right.
And so to start out with, I thought it would be good to first identify exactly what a virus is. So we have a lot of pathogens that you can get infected with, ranging from large worms down to a single proton, which would be a prion. And so viruses are sort of here in between. They are considered non-living or acellular, and that is because they're obligate intracellular pathogens. They need the cell, they need the enzymes within the cell, they need the energy from the cell in order to replicate. If a virus is just sitting out by itself, it's not going to replicate. It has to infect a cell in order to make more of it. So they are infectious agents. They are made up of either the nucleic acid, so it's going to be either an RNA or a DNA, And that is going to be then surrounded by viral proteins. And then in some cases, it'll have an envelope that's going to be made up of cellular lipids and then a mixture of viral and cellular proteins. And so these are going to be very small. You're not going to be able to see them. And so if we would compare in size, so here's a cross section of your hair. Down here is your virus. So it's about 5,000 times more narrow than the diameter of a width of a single strand of hair. And so it is very small. It needs to be in your cell. And in the case of the coronaviruses, they are RNA viruses. So they will mutate quickly. And so that is why sometimes it's hard to find treatments and to find vaccines for viruses. And so if we look specifically at coronaviruses, they are going to be what we call positive sense single-stranded RNA virus. And so it basically has a string of RNA, so it has only one strand, and this RNA will look similar to the mRNA that your cells make. And that mRNA is what is translated into protein, and the same things happen for viruses. The cellular machinery will recognize the viral mRNA and translate into a big viral protein. And so the viral RNA will associate with capsid proteins, and then surrounding it is going to be this coat or an envelope that is made up a lot of glycoproteins. And you can see that they shoot out and sort of form this halo around it. And so if you look at a cross section of coronaviruses on an electron micrograph, you can see there is this halo, sort of like when you have an eclipse, you get the halo around a moon. You have that around the coronaviruses, hence the corona or the crown, and that is due to these glycoproteins. And what's interesting is we normally say envelope viruses are not going to survive on the surface for long. They really need to be in an aerosol or a liquid in order to remain infectious. Well, coronaviruses are sort of, they don't always follow that rule. You can see that there's not too much room here for any cellular lipids. There's a whole lot of viral glycoproteins here. And so those glycoproteins protect the virus and they let it remain on the surface for extended periods of time. And so the virus can survive harsh environments. It even can survive the gut. And so normally you think naked viruses are what are going to be going through the gut, but coronaviruses can cause gastrointestinal symptoms. So most coronaviruses are going to be spread through aerosols, and they cause about 10 to 15% of all upper respiratory tract infections. And so that's going to be your infections from your nose down into your throat. This is because most coronaviruses can only replicate at temperatures lower than the human body temperature. And so it's usually only when the viruses mutate to change to be able to grow at higher temperatures that they be able to infect cells further down into your lower respiratory tract. And once they infect there, they'll induce more of a systemic disease. They can cause the acute bronchitis and even lead to your pneumonia and just respiratory distress. And so this change of being able to grow at warmer temperatures was what we saw with the outbreak of SARS and MERS within the last 2 decades. And the leading to the infection of the lower respiratory tract it was bad for everybody, but it was also more severe in the patients over the 65 years old or those with other comorbidities, which is similar to what we are seeing currently with this new coronavirus.
Okay, so when it comes to diseases, it kind of doesn't matter whether it's a virus or bacterium. They often tend to follow the same path into your body. Their course is generally kind of similar. So all infections are going to start with a reservoir or a source of infection, and that can vary, and we'll talk about that in just a moment. But I'm going to train you to be a little microbiologist right now, and I need you to assume that every surface you touch is contaminated. So your phone, your face, your elevator buttons, everything is contaminated, and you should believe that and live your life that way. Or maybe within risk, or managing your risk is what I'm trying to say. So in order to cause infection, the agent first has to get inside your body. And so that is what we call colonization. And they need to be able to find their target cell population and start their disease process. During that time, they also need to be able to evade your host defenses. And then they will start inflicting their damage on your body. But that's not the end for them. As far as survival of their species, or so to speak, they have to get to another host. And so the last piece is getting out. And with coronavirus and many other respiratory illnesses, that is through coughing or sneezing. And so that is their mechanism of exit. Okay, so I mentioned reservoirs, and there are a number of different things that can impact humans. Humans themselves are reservoirs. We can be infectious without knowing it and transmit to others. We can transmit indirectly. So for example, you blow your nose on a tissue, you leave the tissue for your mom to pick up, because that's what moms do, and she picks it up to throw it away for you, and now her hand is contaminated. She touches her face, and there you go. Now she has an infection. And so we've seen this for different diseases before. And there are certain infections that have really long incubation periods, and during that time, often they're infectious, and so that's part of the reason why we see really widespread dissemination of illness sometimes. You can also have animal reservoirs. You've probably heard of Lyme disease. That's something that's transmitted by ticks, for example. Malaria is transmitted by mosquitoes, but it can also be animals. Like you get bitten by a rabid dog, you contract rabies. And I think all of the coronaviruses that we are concerned about have had some sort of an animal interaction at some point. And so for MERS, it was camels. And that was how it transmitted to other folks. And then we have one of the most worrisome things, to me at least, and that is our non-living surfaces or non-living substances. So for example, I mentioned, elevator buttons or your phone. Those are non-living surfaces that can harbor infectious agents, but soil, water, all of these sorts of things.
So the idea of getting a virus from an animal reservoir is not a new idea. And actually last year there was a paper published where they predicted that in future we are going to start seeing more and more of coronaviruses coming out from the bat population into intermediate animal hosts, and then those intermediate animal hosts will be able to transfer the new viruses into the human population, because all that would have to happen is a small mutation so that in addition to infecting the bat and the intermediate host, it can also infect and replicate within the human cells. So there's not much of a change that would have to happen for this spillover to occur. And as Dr. Schmidtke said, all of the coronaviruses are starting in bats, but with SARS, it went into civets and other small carnivores. With MERS, it went into camels. And in COVID, it's thought to have gone through I'm going to say this wrong, but the pangolin. And so it's important to think of animal workers and the healthcare workers who are going to be coming in with either the infected animals or intermediate hosts and the infected humans, because they are going to be at the greatest risk on the emergences of these highly pathogenic viruses that are originating from bats.
And so, we have reservoirs. We've kind of highlighted a little bit of this so far, but there are different ways that you can get infected by another human. You can have direct contact transmission by touching one another, that sort of thing. We can also have the indirect route, which is what I mentioned with the tissues, for example, touching contaminated bedclothes or plastic surfaces. And then we can have droplet nuclei, which we see a lot in respiratory illnesses too. And so there's this great image of a sneeze, and people aren't often aware of how far that can spread. With these, they travel under a meter usually, so about 3 feet. It's short distance travel, but if you happen to get that on you, that can be your route of infection. And so that's important when we talk about covering your coughs and sneezes, and that's why they're telling you to do that. Now, with respect to fomites, this just came out a couple days ago. They've already started to do some work with looking at how long the virus can remain viable when aerosolized and how long it lives on common surfaces. So for aerosols, they can remain viable in the air for over 3 hours. Now, what you're looking at here is, this is the virus of concern right now in red. That is COVID-19. This one is SARS from the 2002-2003 outbreak. And so it lives, or it doesn't live, it remains viable in air for up to over 3 hours. That's the length of time that they cut off their test. But more concerning to me, I mean, that is concerning, but another thing to me is how well it does on certain surfaces. As we go through this and we start implementing social distancing, there's going to become a bigger reliance on home delivery of cardboard covered packages, whether it's groceries or supplies from Amazon, et cetera, And it turns out that this virus can live or remain viable, on cardboard. This is the median, so about 8.5 hours. It remained for up to 24, but this is what they saw as the median. It's also having a long viability time on steel and plastic. So steel, think of handrails, doorknobs, any metal surface, for example. And so, this is going to be, this helps to sort of explain why we're seeing, one of the reasons why we're seeing such widespread illness. As I mentioned before, a lot of diseases tend to follow the same track within the body. And of course, the time duration can vary depending on what you are. But usually it all starts with an incubation period. And during this time, people may or may not display symptoms. That's followed by a prodromal period where you sort of start to understand that something's off. You don't know what it is yet, but you feel like you're coming down with something. The most severe signs and symptoms will appear during the period of illness. And if we look at this table or graph, what it's showing you is the number of microbes. So this could be virus, this could be bacteria, but as they replicate or divide and their population increases, we're going to start to see more of those symptoms. At the apex here, a couple different things can happen. Your immune system can start working to clear the infection. If it's a virus, it may run out of cells to infect. You may start sloughing the cells that are infected. We usually describe things like a diarrhea as a self-limited illness often because you slough off or sort of pitch overboard your gastrointestinal lining. And so that kind of takes care of the problem in a way. And then following that is a period of convalescence. Now this whole span of time, like I said, can vary depending on the illness. For COVID-19, the median length of time between the onset of symptoms and the start of convalescence is 9.5 days, with a range of 6 to 11 days. So by the second week, people should be starting to feel better, or towards the middle to late part of that week. That won't necessarily be true if you have an underlying condition, of course. And I should mention that with COVID, it seems like during this entire time, you are infectious. And so that's especially concerning. With COVID, its incubation period is 4 to 5.2 days, depending on which paper you're looking at. And so that's a long time to be carrying the virus without displaying symptoms. During that time, you don't know to stay home. You don't know to cover your cough, although you should be doing it all the time. You just don't know to do those things. And so we're especially concerned about folks during this period of decline and the period of convalescence, because this is the time when the virus has knocked down a lot of your barriers, it's spent a lot of your resources, and you're not as well equipped to fight a second infection if it comes in. And so that's an area of concern.
And so what specifically the virus is going to be doing on an infection is following exposure to these respiratory droplets. However you come into contact, the virus is going to infect either the upper respiratory tract or your lower respiratory tract, and it's going to infect your ciliated epithelial cells. And you can see here, this is again an EM showing, you see the cilia, they sort of wave up at the top, sort of like what the anemone in like saltwater tanks, and they offer protection. They offer a barrier so that microbes can't come in, but then they also allow a movement to sort of get rid of bugs before they can infect the cell. And then you have long columnar epithelial cells, and this is going to be in your nasal pharynx down into your respiratory tract. And so the virus will infect these cells. And following infection, you can see the drastic changes that are occurring in these cells. You have the loss of the cilia, you have disruption of the cell surface, you start to see these huge, they call them blebs, there will be cell damage, the cells will start to die, and once they die, then you have lost that barrier. And so you can imagine in the upper respiratory tract, that would be bad, but also in your lower respiratory tract, that's where you're breathing. This damage is also going to induce inflammation, bringing in other immune cells, and in the viruses that can infect the lower respiratory tract, remember, they can replicate then at our body temperature, and so they can then also infect other immune cells, such as your white blood cells, your leukocytes, such as your monocytes. Those are involved in your innate immune response, and the virus can also infect your lymphocytes, which are your cells required for immune memory to offer you protection down the road. And so infection of these white blood cells that travel usually through the blood also, it can lead to some systemic disease and also more severe disease within the host. And it is drastic to see the changes that are occurring once the cells are infected. Now, we've been talking a lot about upper respiratory and lower respiratory. So I thought to just give a quick image to show your upper respiratory tract is going to be your nasal cavities down through your throat, and then your lower respiratory tract is going to be your trachea down through the bronchi and your lungs. And there are set symptoms that are associated more with an upper respiratory tract infection, such as nasal congestions, runny nose, a headache. Usually it's more of a low-grade fever. You'll have sinus pressure. And then with a lower respiratory tract infection, it's usually a higher fever, a more severe cough that starts to be productive, can lead to coughing up blood, can have wheezing, difficulty breathing, tightness in the chest, and you can also start to develop hypoxia and your skin can start to turn blue.
And to be clear, this is a more generic sort of summary of symptoms that you might expect in an upper or lower respiratory tract infection. We'll go through the specifics of COVID in just a moment.
Yes. And so for COVID, what we are going to present with, again, this is going to be about 5 days after you're infected, that most people will develop just a slight fever, cough, they'll be tired. They just won't feel that well. It will just seem like your normal cold. However, those who are at an advanced stage or have other underlying comorbidities, they can develop more severe diseases such as the headache, production of sputum, coughing up the blood. They can get diarrhea. They can have a decrease in their white blood cell count, trouble breathing, and then respiratory distress and even organ failure. And so it is important, really important, to remember that everything for most infections is going to be a triangle. Most of us are going to be down here at the bottom. We're going to get mild cases, very mild symptoms. It's going to could seem like allergies. It could seem like just a normal cold. Most of us won't be going to the doctor. We won't be getting tested. And so most of our mild cases are not going to be counted. And I think even in China, most of the mild cases are not counted. And that can throw off survival curves and everything like that. So there will be a good number of cases that people will develop more severe symptoms. You're going to have shortness of breath, increased breathing, tachypnea, but they won't have signs of severe pneumonia. These people will have some difficulties with everyday things, but it won't be severe. There will be a smaller number of cases that are going to be severe, where you're going to have respiratory distress, hypoxia, cyanosis, and more dangerous symptoms. And then only a small percentage is going to lead to death. And so it's important just to remember, we will have a lot of mild cases. A lot of these mild cases are going to be involved in the spread, but it's only going to be a very small percentage that is going to lead to severe infection and or death. And so again, if we look at both the systemic disorders or signs that are associated with the COVID and also the respiratory disorders, the biggest ones are going to be a fever, cough, shortness of breath, but it can lead to cardiac injury, hypoxemia, and other negative outcomes. And so if we look at clinical features of what infected patients will display to either their doctors or the hospitals, is most severe infections are coming in showing as a bilateral pneumonia. And so that they'll have infiltration in both the sides of their lungs. People who are better at looking at, better radiologists than what I can ever guess looking at the CTs and X-ray images, they can spot what they call the ground glass opacities in these patients. Most of the patients will come in with abnormal respiratory findings. They'll have decreased oxygen saturation, increased breaths per minute, and just trouble breathing. Most people are coming in with decreased white blood cell counts. And this is really abnormal because usually with infections, the patient's white blood cell number will increase. And so this decrease in the number of white blood cells is going to be a negative prognostic factor in these patients. So along with analyzing the blood, the patients will have an increase in pro-inflammatory cytokines. To think there's a lot of inflammation going on in their lungs. And they're also going to have other signs of inflammation, such as an elevated erythrocyte sedimentation rate. They're going to have elevated liver enzymes, an elevated C-reactive protein, muscle enzymes, and lactate dehydrogenase. And so these are important to show that there is going to be cell death occurring, tissue injury occurring, and everything else. What is interesting, because of that tissue injury and cell death, normally when that occurs, procalcitonin levels will increase, but the doctors are seeing that with the coronavirus, procalcitonin levels are normal in these patients. So that is one abnormal finding. And so in addition, some other things that doctors will be able to see is that they're going to be able to detect the viral RNA in the blood. The patients can develop into acute respiratory distress syndrome. They can have cardiac injury, and again, those ground glass opacities in their lungs. And so if you're trying to do a diagnosis for the coronavirus, the first thing your doctor will do is he or she is going to run an influenza test. Unfortunately, this is also the time for influenza. It's influenza season. It's also time for allergies. We're starting to have a lot of pollen and yellow cars and everything like that. And so they're also going to look for you for allergies. They also have to rule out a lot of other respiratory viruses in this differential. And so what they're going to do to test for coronavirus, if they decide they need to do that, is they're going to, remember this is an RNA virus, so you're going to do reverse transcription of that RNA to make it into a cDNA, and then they're going to do real-time PCR to see if they can detect the viral nucleic acid. And so what PCR is once you make the RNA into the cDNA, you go through rounds of denaturing, annealing these specific primers, which are short nucleic acid strands that the CDC does have established primers for diagnostic. And so these primers will anneal to a single strand and then elongate, and it will double every cycle. And so they'll use this in order to establish that there was a positive infection. And so it's important, again, to think this is the time also for other colds, other viruses. It's also the time for flu. And so some of the things to determine if you think, oh, I might have coronavirus and it might be severe, is to first consider, do you have upper respiratory or lower respiratory tract infections? Probably if it's upper respiratory, you don't have to be too concerned. If it's getting more to lower respiratory tract symptoms, then you might want to go see the doctor where you're starting to have coughing, shortness of breath, and you just have a lot of fluid in your lungs. And there is, again, with the coronavirus, the possibility to have the GI symptoms because it can survive in your gut. And so the way that people have been treating the coronavirus is the biggest thing is patient isolation and quarantine of the people that are associated with them in order to try to delay spread. They also, you just want to really treat the symptoms, do reduce the fever, replace fluids, give them oxygen, anything to help their organs and everything else. So just supportive care. And the big thing is to just avoid the steroids because you don't want to inhibit their immune response. And so the big question is always, well, what about antivirals? We do have some antivirals. Are they going to work? And there is some good news in that there are some antivirals that have shown promise with treating the coronavirus. The two main big ones are the nucleoside analogs, which the nucleoside analogs, these are going to mimic your nucleosides, and they're going to be incorporated into the viral RNA, but they're modified in such a way so that the polymerase can't keep on replicating past that nucleoside. And so it will halt virus replication. And they've seen that some of these nucleoside analogs are able to inhibit multiple virus infections as well as specific coronaviruses and some pre-emerging bat coronaviruses. The second class of antivirals are going to be your protease inhibitors. Remember, this is one long mRNA that's made into one polyprotein. And so that polyprotein has to have a protease to cleave it up into its functional protein units. And so the HIV protease inhibitors have been found to be effective against the coronavirus proteases so that they can inhibit the cleavage of that polyprotein. And they've tested these in the past viruses, and it has shown promise. And then interestingly, recently, China has reported that they started treating their patients with chloroquine, which we usually think chloroquine, use that to treat malaria. Well, they're finding that it does have broad antiviral activity and has possibilities of stopping or inhibiting a coronavirus infection. And so treatments are good, but the gold standard is, can we make a vaccine? There's been a lot of talk recently about vaccines and things. So when you start thinking about vaccines, you want to think, what would be the best target for a vaccine? Well, for a virus, what you want to stop is the ability of that virus to infect the cell. So you are going to want a vaccine to some of these glycoproteins on the outer surface. Unfortunately, with coronaviruses, there is not much similarity or identity between the different coronaviruses in the sequences of these outer glycoproteins. And so because there's not any conservation, there's not going to be the ability to easily make immune memory or induce immune memory within the patient. And so that is one of the big disabilities, because there are so many coronaviruses out there. There are so many pre-emergent bat coronaviruses. The possibility of making one vaccine to target them all is going to be difficult. Adding to this difficulty is the fact that in past outbreaks, they've made potential vaccine formulations, and they found that they don't protect animal models. They tried them in human patients, and they found that in the young, that the vaccine actually increased the immunopathology in these patients. So it would have a negative outcome, and you wouldn't want to do that. And so the need in the future, if we want to make a coronavirus vaccine, is you're going to need to have a vaccine platform that you can rapidly adjust to put in these new emergent viruses and then rapidly make it. And so it just is going to take some time and some testing to figure out the best way to do so.
Okay, so that was a lot of technical stuff. And so if you were feeling lost right there, don't worry, we're going to get you back right here. And so thank you very much. This is super helpful. We're going to start talking about why is it spreading the way that it is. That's our next thing. And why are we having such difficulty with containing it? So this is a graph or a video that I use to demonstrate how herd immunity works. So remember that this one has a lot of subclinical presentations. So we have a lot of folks that are sick or carrying the virus, but we don't know it. And we pair that with the fact that nobody is immune to this. So we normally use this to demonstrate the importance of vaccination. And so in these images, you're going to see an infected person who is in black, and that's hard to tell with the colors here, but they're the person in the middle. And then you have unvaccinated individuals or non-immune people, that's what we should consider them in this case, that are in blue. And then those who have been exposed through natural means or vaccination will appear in yellow. And so normally when we're talking about something like polio or other things that we have vaccination for, we're usually somewhere in this 90% zone. And so keep an eye on that, but also keep an eye on what happens here, because this is our current situation. So you see the way that the virus spreads, because there's nobody that's immune. So what that means is that if you are exposed, if you contract it, you are able to pass on to others. If you were immune, it would hit you, but it wouldn't be able to spread beyond you. And so this is the idea of herd immunity, and we will come back to this at the end of the talk. There we go. All right, so the way that it spreads to other people is described by epidemiologists as the basic reproduction number, or R naught. And this is something that's gaining traction in the news media. You're starting to hear this talked about. And so what I wanted to do was demonstrate how COVID compares to other common or not so common viruses. So for COVID, that's this one here. And so R naught basically is if I'm infected, which I'm not, how many, and I cough, how many people will I infect? And so if an R naught value is less than 1, a virus is likely to peter out. It's not going to cause widespread disease. If its number is above 1, then it's likely to continue and spread. So as a point of, and as the R naught value increases, the more spreadable a virus is. So for influenza, its number is about 1.2. And so that's what we're looking at here. This is seasonal influenza. If we look at COVID, you can see that just even graphically, the number is higher. And our R naught value for this is somewhere between 2.2 and 3.28 people. So you are able to infect between 2 and 3 people, basically. Its close cousins, SARS, one of them is SARS, it was able to have an even higher R naught value and had a higher case fatality rate as well. And then MERS, which was another close cousin, had an R naught value of less than 1. So thankfully, it didn't spread far, and we should be thankful for that because it had a very high case fatality rate of 36%. That is, all things considered, this is still a low spread sort of virus compared to things like measles and smallpox, which are some of our more super spready sort of viruses. Another thing to point out is in Wuhan, the epidemic has been doubling in size just about every 7 days. So if they had 40 cases today, they would have 80 cases next week, for example, and it doubles every time. And early evidence is showing that the virus can remain in a person's body and they can be shedding it to others for 37 days with a median time of 20. So just because you've recovered doesn't mean that you're necessarily not spreading to others. It's important to, still sort of keep those protective measures in place for yourself to, try to limit your interaction with others. And one other thing I should mention before we progress is that a lot of this information is being thrown up very, very fast, and there hasn't been a lot of opportunity for peer review. There have been some things published to the New England Journal, for example, that I've referenced here that it explicitly says in big, big letters, this has not been peer reviewed. And the other thing is the information is just really, really new, and we don't have a firm grasp on what's going on. So in 6 months from now, some of these numbers might change because we'll have a better sense of what happened. So don't hold us to this. This is just what the current information is. All right, so if we look at what's going on in Georgia, this is the most recent information as of midnight last night. So these are the cases. We have 42 right now in the state. That's a jump of 11 in the last 24 hours. They are mostly concentrated in the Atlanta metro. We do have some cases in more rural spaces, and also at Moody Air Force Base, there was a person working there that got infected. Unfortunately, yesterday, we had our first death that happened in Cobb County. And so Governor Kemp held a press conference, and we'll talk about that. But the other findings that we have so far from Georgia Department of Public Health is how it's affecting different age groups. You'll see that most of these people are in this, actually, we have a pretty good split between 18 to 59-year-olds and people over 60 so far. We do have an unknown, I don't totally understand that, but then we've got 1 kid so far that's got it. It seems to show a predominance for males so far, so we're not sure if that's something specific to, it probably has very little to do with biology and more to do with exposures and things like that. But at the press conference yesterday, Dr. Kathleen Toomey from the Georgia Department of Health gave some really interesting information about testing. Currently, they're able to run 50 samples a day. With that RT-PCR that Dr. Bentz explained, next week, their building capacity, they should be able to test 100 a day. And they currently have enough supplies on hand to run 500 samples as of right now. And I know that there's a lot of frustration with the testing and why aren't we doing more of it? And we can talk about that at length, but I talked to a friend this morning who works at CDC and is one of the laboratorians doing this. And one of the big problems is the viral extraction. So when we get a clinical specimen, that has to be cleaned and you have to isolate just the virus so that we can start doing that PCR. Because if you have contaminants in there, that can give you a false result. And so normally they use robots or automated equipment to do that process, but they found that the yield was really low. And so they've had to go to fully manual extraction where a person is doing it. And in order to do that, you have to, so that's of course a rate limiting step because you've got people involved that have to do the work. They have to wear significant PPE. This is not the Gumby suit that most people think of when they see the movie Outbreak. This is a step below. This is called a PAPR suit. Where they're using a respirator that they wear. And the labs that are doing this have to be certified by CLIA, which is a clinical laboratory standards sort of thing. And so it's limited who can do the testing. And so that has kind of held things back. Okay, so if we look a little broader outside of Georgia and we look at the nation, this is where things are as of yesterday. CDC missed their data dump at noon today. I'm sure it's coming, it just hasn't come yet. It's present in 42 states as well as the District of Columbia. We are here, so we are in the 21 to 50 range, which makes sense because we're at 42 today. You can see the hotspots are in New York and Washington and California. And so that's where we're seeing some of the more aggressive measures being put in place to try to contain or limit the spread of illness. This is what's called an epi curve or an epidemiologic curve of when cases were reported. This is slightly out of date information. It was up till March 11th. They have not updated it since then. And so what we can see is that it starts small and then increases. Sorry. And then we're in this window of time right now that's kind of like a black box. We don't know what's going on right now because there's not adequate reporting to CDC and these numbers are a little bit unreliable. But as of last night, there were or yesterday, there were over 1,200 cases and 36 deaths so far in the United States. And I should mention that this doesn't include certain individuals that have been repatriated from overseas. And of course, we've got the black box issue. This is what's going on internationally. So of course, you know, we are here. And one thing I want to point out about this graphic, it's a little confusing sometimes because the areas that are affected are in white. The areas that are unaffected are in gray. So normally we would color the things that matter, but in this case, they're white. And so far, it's had a pretty decent spread. Of course, China was the epicenter of the outbreak, and then it spread to Korea, Japan, and elsewhere. Other hotspots include Iran, Italy, and of course, we're now starting to see an uptick in the United States. In the last 24 hours, they've added 4 new countries or areas. And so these numbers come out every day. You can go check them out for yourself. They're on the WHO website. But that's where things are internationally. And if we look at their epi curve, here's a stacked graph where what you're looking at is the total number of cases and the proportion of them that come from different areas of the world. So for example, right here in this sort of salmon color, that's Europe. And in purple is Eastern Mediterranean. So that could be like the Turkey and Iran cases. And then here at the tippy top is us. We are in the Americas, but because we're not doing widespread testing yet, this may be more of a Latin America sort of influence, but we should expect these numbers to rise. I was telling my small group a couple days ago that what we're doing right now is basically fumbling in the dark with a flashlight, looking for something in a dark room. And you don't find what you're not looking for. And we're starting to look and we're going to find it. It will be the equivalent of turning on the overhead light in that dark room. We are going to find a lot of it. So I want you to not panic when you see the case counts jump dramatically in the next couple days, week, whatever, whenever it's going to be. We are going to see a lot. And remember from Dr. Bentz's information, not all of them are going to be severe. Most of them won't. But as of now, we have over 125,000 confirmed cases, and that's a jump of 6,700 since yesterday. We also have 4,600 deaths. And if you do that math, that's about a 3.7 case fatality rate. So it's higher than what our initial estimates were. So we'll see how this plays out. And so I know that you've seen headlines like this so far. We've got situations where parades are being canceled, and we've got March Madness canceled, and all sorts of things. Schools are closing. But there are some things that stand out that I want to mention as we start talking about the idea of social distancing and why these things are happening, why they're being done. And the situation I want to draw your attention to is what's going on in Italy right now. So Italy did not respond aggressively to this outbreak. They didn't implement social distancing measures right away. And so what they've seen is an overwhelm of their hospital infrastructure. So they have more patients ill than they can treat. And so they're having to do effectively like battle triage right now to decide who can they save with this ventilator and who doesn't have enough life years to justify using that equipment. And so people are dying needlessly because their healthcare infrastructure is being overwhelmed. And so that is why you're starting to see things close. And of course, things don't ever become real to people until it affects somebody they know. And so Tom Hanks was just infected, and Disneyland just closed. And so for a lot of my friends, that's when it became real for them because they've grown up with Tom Hanks in their life. And that's an unfortunate reality of infectious disease, is that it doesn't matter until it matters to you. So, and then of course we have situations where folks are not obeying quarantine and infecting others. So as we see things get closed, if we see communities get sort of cordoned off, part of it has to do with situations like this. So the idea behind social distancing, a lot of it comes from what we know from an outbreak that happened 100 years ago called the Spanish flu pandemic. This was in 1918, and I'm going to highlight two cities and their different responses for this. So Philadelphia and St. Louis. Philadelphia, they had their first case on September 17th. They went ahead and had some sort of parade festival inside their town on the 28th, and they didn't start closing schools or banning public gatherings until the 30th of October. So I think that's like 16 days later. And this is their epicurve. So their, or not epicurve, this is their death rate, excuse me. So cases per 100,000 in the population. St. Louis took a different approach. They had their first case on the 5th of October, and they started closing schools and banning public gatherings on the 7th of October, so 2 days duration. And what you see here is that they flattened that death rate to something much smaller, something more manageable. And so this is trending on Twitter right now, this idea of flattening the curve. And the reason why we want to do this is because we have a known limit to what our healthcare infrastructure can tolerate. And so when you have uncontrolled transmission without social distancing measures put in place, your death rate can, or case count can approach something like this. The idea of implementing social distancing measures like closing March Madness, closing schools, that sort of thing, is to limit transmission to a level that we're all going to get sick maybe, but we're not all going to get sick at the exact same time. And that's what we're really trying to prevent. So we can look at how different countries now are handling this and how that has affected their case counts. So Iran has had a really, really hard time, and it spiked hard and fast for them. And so this is probably out of date information now. It was the 11th when I put this together, but they had 9,000 cases. But you see that we have an exponential increase in the number of cases. It's not just one person affects another. It doubles virtually with every person who's infected. Italy had a similar response, but they were thankfully able to, for whatever reason, able to space it out a little bit longer. But they are seeing, like I said, really hard choices they're having to make, and their hospitals are overwhelmed. South Korea had a similar sort of start, but they were able to quash this with really aggressive social distancing measures. And so they are approaching the leveling off of their exponential curve, and so that's really great. Japan implemented really strict social distancing. They have had a flat curve that's more reminiscent of St. Louis in that earlier diagram that I showed you, and Singapore as well. The US is here. We're in this sort of teal line. We're at, this is outdated, like I said, about 1,000 cases, but you can see our line here. And so far it looks more like Italy or Iran than it does Japan or Singapore. So this is the reason why you're seeing public bans, or not bans on public gatherings, but things are closing. And that is to try to have this, it's really sort of a collaborative effort among humanity to be like, we know what the problem is about to be, and we're doing what we can to protect the most vulnerable. So I think if you can approach it from that direction instead of a doomsday situation, I think we're all going to be a whole lot better off. So the people we worry about most, it's not about you. I'm sorry. It's not about me. It's about my dad. It's about, those sorts of folks. And so we're worried about people that are over 60 years of age and people that have underlying conditions. Sorry, I shouldn't. Okay. So I don't know why this is happening. But people with heart disease, diabetes, or lung disease, these are folks that we're worried about. We're also worried about the immunocompromised. And normally that would include pregnant women, but so far we're not seeing the severe cases in those folks. And so we're really glad for that. But we are concerned about people that are taking immunosuppressing medication and those sorts of folks. There are some emergency warning signs you want to be on the lookout for, especially if you are staying home and managing this and you have one of these individuals in your home. And so that's going to include difficulty breathing or shortness of breath, any sort of pain or pressure in the chest that doesn't go away, if there's new change in mental status, or if they're showing signs of hypoxia with those bluish lips or face. And so things you can do, this is what we want to do, right? This is the things that we can do as individuals to try to help. And so the first thing is to observe really, really strong cough and sneeze etiquette. So that means that when you're clearing your throat, when you're coughing, you are not doing that into the ether. You need to be covering those sneezes and coughs. So I tend to do a lot of elbow covering. I also use the top hem of my shirt, for example, but you'll see people do different things. What you really want to avoid is coughing into your hands, because you use your hands to touch everything, and then you use those hands to touch your face. So, and we'll talk about that. You want to stop touching your face too, which is really hard to do. So the next thing you want to do is observe really good hand washing. So the cool thing, and we got really lucky on this, is the fact that the virus is enveloped. That makes it super vulnerable to soap. I mean, just general soap. You don't even have to have antibacterial or like hospital grade soap. Any soap will do this. But contact time is really important. And so we're going to talk in a second about how long you need to wash your hands, methods for doing it well. But I have made it practice in my home, and I think you should too, that when people enter your home, often people will take their shoes off, and that's just part of their standard custom. Your new custom is every person that enters your house every time needs to wash their hands. And if you can do that, I think you'll really help yourself. Again, you need to avoid touching your eyes, your nose, your mouth. Maggie, did you keep track? How many times have I touched my face? So we are trained. Thank you. We are trained in this. This has been part of our upbringing to not do this. And it's still something that we do subconsciously. So I empathize. I realize how hard this is, but do your best to avoid touching your eyes, your nose, your mouth. We need to be given lots of love to our janitorial staff, because we need to be cleaning those high frequency surfaces like buttons and handrails and doorknobs and light switches regularly. The evidence shows that. And it's not just them. You have the power to do that. We need to be gathering supplies responsibly. I know you've seen that there's a run on toilet paper right now. And no, this is not a diarrheal illness, but people are recognizing that if I told you right now that you are positive for COVID, which I thankfully hope you are not, if I told you that you have to go home right now and not stop at a grocery store, could you stay there for 2 to 3 weeks? And that is why we're seeing scarcity of certain commodities. But you need to think about things like medications, food for every person in your house, pets, and maybe start using grocery delivery or grocery pickup services. You need to have the phone numbers of your neighbors, and especially elderly people that you're around, because you could be their lifeline. And so I think it's important that you check in on vulnerable populations. If they're out of toilet paper, be a good neighbor. We're not sharing a cup of sugar anymore, it's toilet paper. We need to start making a plan if you haven't already, because we've seen schools close, and it's going to have impacts on the ability to work, the ability to go to school yourself if you're affected. And so you need to have a plan for how you're going to manage and mitigate that. If you do, you should anticipate that somebody in your house might get sick. And for that, one of the best things you can do is set up a room that is dedicated for that situation. Maybe a bedroom that has a bathroom attached to it. Give them the iPad, let them watch Netflix, and just have them there, bring their food to them. Okay, so this is more of the same, but.
Yeah, so hopefully you guys have all seen this from I think it was from the CDC, where it does just sort of highlights everything where it says about how you, with your sneezing and coughing, it can spread within 6 feet. And so you do want to clean those handrails, doorknobs, everything. I know over in the undergraduate science building, they're wiping everything down twice a day. That's probably a really good practice to do. Also to sneeze and cough into your elbows. That was something I was never taught when I was little. And so I'm glad when my kids actually do that, because that's what they're being taught to do now. Again, don't touch your face. The big thing though is when you're cleaning your house, how many of you spray it down and wipe it up immediately? Yeah, that's not going to really kill it. If you actually read the back of the labels, it will say usually you need to have a visibly wet surface for up to 10 minutes. I've seen some that say it has to be visibly wet for a half an hour. And so, because it takes some time to kill it. It's not like washing our hands where, yes, it's the soap, but then also the friction of rubbing your hands. It just takes some time for the bleach or the disinfectant to actually disinfect. So read the back of your disinfectants and follow the instructions on how long to leave it wet. I did see something that was pretty funny. It was talking about bleach and making a bleach solution, but they did make sure to point out, don't put it on your couch because it is bleach. So try to remember that too. And then remember to stay home when you're sick, but also to remember, be a good neighbor. Be nice to those around you. You're there to protect yourself, but also to protect your neighbors, your friends at church who are in the more at-risk populations, your coworkers. Social isolation, it is there to protect others and just to basically be a good person. And then finally, washing your hands. Hopefully you all know that it's the 2 happy birthdays. If you get tired of singing happy birthdays, you can go through and sing the ABCs and go all the way through now I know my ABCs. Next time, won't you sing with me? You can also do Twinkle, Twinkle, Little Star. You can do the chorus to Jolene or the chorus to Karma Chameleon. And I actually did go through and sing them out. And I think Jolene went to 24 seconds. Karma Chameleon went to like 21. And so I won't sing them for you, but just know 20 seconds is a little bit longer than what you think it is. And so when you're washing your hands, this is looking at your hands where the glowing, it's green, where glowing is the germs, it's going to be bad. Before washing, you can see there's a lot of glowing. Oh, how many you just go in and wash? Okay, I'm done. It does not remove anything. Look, it takes up to 30 seconds with soap to get almost everything gone except for your nails. And so you really need to make sure you're doing the 20 minutes, doing soap and washing your hands. Because then you can also look at areas that are frequently missed. So if you look at the fingertips, your thumbs, those are frequently missed. And then going back down on the back of your hands, those are also frequently missed. And last week I was in a meeting with the dean and she was like, you also want to be careful. You don't want to, after you wash your hands and you're going to get your towel, you don't want to go like this. You want to keep your hands up, because if you go like this, anything that is like on your arms that you didn't wash can come down onto your hands. So think about those images of those surgeons who are scrubbing in before they go into surgery. They walk like this. And so wash your hands. You can maybe reach over, get the elbow to turn the faucet off to go get your towel, and then wipe it down, not up.
Okay, so another common question is, do you need a mask? And the answer is most likely no. Speaking of the surgical situation, when we see people, you've seen it in movies, when they scrub up and they go into surgery, you notice that they're wearing a mask, they're wearing a gown, they're wearing a cap, they're wearing booties. Is that to protect them from an infection from the patient, or to protect the patient from getting an infection from the surgeons and staff? It's the surgeons and staff we're worried about. So only if you are displaying symptoms do you need to have a mask, or if you're treating someone who is, but that's not going to be the majority of us. And what I would be very careful about is that masks tend to provide a false sense of security. People will become fearless when they have them on. They will do risky behaviors that they wouldn't do if they weren't wearing a mask. And they're very easy to contaminate. If you touch the front of them, it's contaminated. And then the type of mask matters. There's a special kind of mask called an N95 that's used for some of those respirators that I was talking about, but they require a custom fit to your face for best use. And they're kind of hard to breathe through and wear. So honestly, we need to leave these for the public, or not public health, but the healthcare workers as best as we can. So again, we're back to the herd immunity idea and the idea of the vaccine. Eventually, we are going to get to a point where most of us have been exposed to this thing. And so eventually, instead of a vaccine, we're just going to get it naturally. And so eventually, we're going to get to a point like this where, things will improve. I worked at CDC when the H1N1 pandemic happened in 2009. And for that, the virus was, or the vaccine was available 6 months from the date that they identified which strain they wanted to use. And that was because they already had an established pipeline for making flu vaccine, and all they really had to do was switch the virus. That's not necessarily going to be possible with COVID. It's going to be delayed because of all the issues that Dr. Bentz brought up, including things like efficacy. Does it work? Does it actually provide protection? Is it safe to apply to humans? And then we have the whole issue of mass production. So this is not going to turn on a dime. We are not going to probably have a vaccine for at least 12 months to 18 months, probably. So do not count on a vaccine. We're just going to have to ride this out. So some remaining questions that exist out there and we don't totally know the answers to are recovered patients, people who have gone through this, are they functionally immune to it afterwards? Because we have certain infections where that doesn't necessarily happen. And we'd like to believe this is sort of most viruses do it, so we're going to assume it happens here. But hopefully they're going to be immune so that we can approach something like this, which will protect some of our more vulnerable populations. Another question is there any cross protection against some of the more serious viruses like SARS and MERS? Based on what Dr. Bentz says, it's probably not likely, but wouldn't that be nice? Because then the really scary things we might be protected from. And then so eventually we're going to get to a place where it looks a little bit more like this, and that would be a lot better than where we are now. So some key takeaways. Most infections are going to be mild. So again, this is not about you. This is not meant to be a panic for you. But we are concerned about those who are 60 years and older. We are probably going to see COVID spread to more people than influenza, and it has a higher case fatality rate than influenza. So people may say, well, the flu kills people every year. Well, this kills a lot more people than the flu, and it spreads faster to them. So we need to be very cautious. The social distancing measures that are being recommended, they are a big inconvenience, and this is not how America runs. So this is going to hurt. It just is. But it's there to protect the most vulnerable populations among us, and to allow those hospitals to triage appropriately and make sure that they can provide the best care they possibly can as this crisis unfolds. Of course, and you guys I've seen so far have done a really good job with observing cough etiquette and hand hygiene. Please continue to do that, and you'll be a whole lot better off, and you'll be contributing to the health of your community. So I think that is it for us for now. So thank you.
I did want to mention one thing. I did not realize this before I coached my son's Tiny Tots team. Now might not be the time to be shaking hands with everybody. It's not the time to give fist bumps, high fives, hugs, and everything like that. You might do oh, good job, elbow, or find some other way to greet people. So maybe just a thumbs up, I don't know. But yeah, so also remember, probably don't shake hands for a little bit. So are there any questions?
There are two questions. The two that came in.
Okay.
We'll address that and then.
Those, All right, the first question came from one of the med tutorial rooms. Coronaviruses have been around for years. What about this virus is so virulent? Is it because of lack of previous exposure, possibly like a genetic shift?
So first of all, this is not influenza, so we do not have shifts. Remember, shifts are the rearrangements of the influenza segments. This would be more of a genetic drift because there are going to be mutations because it is an RNA virus. It is going to be because it is a novel virus. It is just coming out of bat. We have never been exposed to it. I haven't looked to see how similar the sequences are to like SARS and MERS, but it is because it is a novel virus. It's the first time any human has seen it, and because it has been proven that it can replicate at the higher temperatures, so it can replicate our lungs, and that is a big part of why it can cause more of a disease.
And to reiterate, we've never seen this before. We have no herd immunity, so we're all going to potentially be exposed to this eventually.
Yeah, all of us are naive to it.
Right now, I'll ask the second question, and then I'll unmute Savannah. How likely is it that the COVID-19 prevalence will go down after the end of the flu season?
So early estimates so far. So with flu, we tend to see it drop off in the summer, and that's often because the virus doesn't survive well in heat. But we are still seeing significant cases in Australia where it's summer and early fall there now. So I don't have any reason right now to suspect that it would go away just because the weather gets warmer.
Yeah, from what I've been reading, they expect, springtime is here, no more virus. I think we're still going to be able to spread it. It's still going to be able to survive outside of ours and still remain infectious.
We had a couple questions locally. Can we address at least a couple of them, and then we'll talk to Savannah? Okay.
So thank you for the talk, first of all. And my question is, you mentioned how we can still be infectious when we've been exposed to the virus, but before we've had symptoms. So how are we infecting others if we're not coughing, we're not sneezing, we're not like, how are we still infecting others?
Great question. So you are still touching your face, potentially because all of us do it. You may be touching your nose, your mouth, whatever, and then touching other things. So that's going to be some of the early ways that you're spreading the illness, even though you are not actively coughing and sneezing. To reiterate what Rima is saying, for example, you touch your face to wipe snot off your nose, or you feel something in your eye, so you touch it, yes, that could potentially have it in there. I think we had at least one more question from Sarah, and then we'll talk to some of our other folks.
The R0 value that you talked about between 2 and 3, is that based on confirmed cases, or do they have a way to estimate that big bottom section of pyramid of cases that aren't confirmed but we know are happening?
That's a great question. So we're not totally sure. I mean, those are based on confirmed cases, but it's important to remember this data is coming out of China, where it was the epicenter of all of this. So there's probably been some errors in reporting just because it's gotten very big, very fast. I will say they've been very diligent about screening. In fact, they've got people stationed like at the entrance of apartment buildings or workplaces or whatever with a thermometer. And if you have a thermometer, you go to what's called a fever clinic, and you don't go home afterwards. If you are in the sense that if you have a fever and they test you and they can run a quick CT on you to look for that lung issue, they will quarantine you or isolate you, excuse me. And so yeah, that number may rise as we learn more information, but as of now, that's the best that we have. One more question locally. Go ahead.
Being that some of us are above that 60-year-old range, how does the death rate go up as you get older?
I didn't bring the data with me to show you, but so I don't want to speak off the cuff, but it does increase by decade of life. And I don't recall the numbers right now, and I didn't bring them with me, so I'm sorry. We do know that there are certain conditions that are more associated with serious outcomes than others, but especially blood pressure is one of them. So I know, great. Okay. Do we have any questions in Savannah so far?
I have a question. So, am I mistaken in that the virus gains entry via the ACE enzyme?
Yes, there has been some suggestion that it can do that. That is the receptor, and that
So
the ACE inhibitors can inhibit it.
So, is that something that people are adding to the treatment regimen?
It's experimental right now. There was a paper that came out just recently about it, suggesting that may be something to try. Honestly, it's almost like throwing darts at the wall right now, trying to see what can be most successful. I think people are just trying to share their best practices
but we'll have to see how efficacious that actually was, sort of in the postmortem analysis of this entire thing.
And also, can we get your power?
Can we get your
Yes, we can.
PowerPoint?
I mean, I don't have any problem distributing the PowerPoint. That shouldn't be an issue. We'll send it probably through Lori.
Thank you.
You're welcome. Local question? 1 sec, we'll wait for the microphone. Or do we have one from,
We have an online question.
okay.
Are cases in China likely declining because so many people have been exposed to the virus at this point, like your herd immunity example? And can we expect a similar epidemic curve in the U.S.?
Okay, good question. Sorry, all questions are good, right? There are no dumb questions. I always fault people for saying that, but then there I go. So the epi curve in China is it is starting to flatten a little bit. They are still, but that is mostly because of the aggressive measures they've taken to sort of lock the population down. In fact, there, when somebody is sick, like let's say a kid gets sick in the home, parents don't stay with that kid. They have special facilities for the kid. They have special facilities for women. They have special facilities for men. So families are being separated in this because they've realized that it may not be safe to self-quarantine or self-isolate at home because you will spread it to your family. And so that is a decision that they have made, and that may be accounting for some of their decline. Now, when it comes to herd immunity, yes, we should expect that eventually as this progresses, we're going to have more exposure and there will be more protection, assuming that people are immune afterwards. But it's going to take a while before we get there. So, right here.
So I've encountered a large number of people who think that it's a hoax, it's not a big deal. I've even seen it on interviews on Fox News that, oh, this is just a mild flu. What's the best way to communicate to these people that this is actually important? Because these are arguably the people who need to hear it the most.
You're not wrong, in the sense that, you know, their viewership tends to be slightly older, and so they're the folks that we need to protect, honestly, a lot of the time. I mean, they have a wide swath of the viewership. But I think more than anything, it may help to know the numbers, in the sense that we know that, for example, influenza kills X number of people every year. We know that it has a case fatality rate of 0.1%. If we took that same population of deaths per year from influenza, we could extrapolate based on what we know for the case fatality rate with this, how many more deaths there would be. Like, this is serious. And I've seen memes about the numbers, and I can tell you that it makes me want to shake my fists angrily in the sky every time I see it, because the numbers will not be funny in a week or two. Not at all. Mm-hmm. I know Pam had a question locally. Oh, but we've got one here. Sorry.
What can we do to protect our parents? Because like my parents are in their 70s, and my boyfriend's parent, his mom, is his last remaining parent. She's like 82. She's got diabetes. She's got a lot of underlying conditions, and I'm just concerned about, you know, she doesn't want to stop going to church. She's very, you know, religious.
And out in Colorado,
And there might be virtual services that are possible that I know that it doesn't have the social component that the elderly may enjoy. And that's something to keep in mind too. We have spoken to the infectious disease aspects of this, but this self-isolation, self-quarantine is going to have significant mental health impacts too. And especially on our more vulnerable populations who already struggle with issues of isolation. So that's another reason to be checking on your neighbors, checking on your family. As far as protecting your individual family, I would hunker them down now. I wouldn't restrict their movement, like lock them in a bedroom, but I would strongly discourage them from going to public places that are commonly frequented. If they can set up a grocery delivery, that is exactly what I would do. Or you can deliver their groceries. Yeah, exactly. So, I mean, anything that you can do to run errands for them will be helpful, but I think it's going to be important also to check in on them frequently. Use FaceTime and Skype. They may hate it, but do it anyway, because we need to know that they're okay. So my heart goes out to you because I completely understand. I will say that my family was supposed to be traveling to Missouri in a couple weeks for my father-in-law's 80th birthday. He has underlying conditions as well, and our family has decided, all of us have decided to postpone this And we'll be doing it via like Skype or Zoom or whatever, because to me, the risk is not worth it to go see him. I know he wants to see the grandkids, but they're little germ magnets, and I am not going to take them to him. Francis.
Yes, so if we go on lockdown, what is happening now, and you say there's no possibility of vaccine in 18 months, what is the scenario, let's say, in fall, in October, November? If the infection is still there, how long can we be on lockdown?
It's a good question, and I don't know. And I should say that I'm not a decision maker. But what I will say is that what we saw with the situation in the 1918 pandemic between St. Louis and Philadelphia was that eventually St. Louis was able to lift some of those restrictions, and you did see their curve rise a bit. But it was at a manageable level. So we will be probably asked to self-quarantine or self-isolate for a while, and they will gradually probably lift those restrictions in a way that makes sense. Like we may not have schools right away, but we may have churches reopening. I don't know what the strategy will be to try to sort of lift the valve slightly so that we can have cases, but it won't be to overwhelm our healthcare infrastructure.
I know I have a friend who has a family member in China, and he went back while this was all happening, and they have a rotating schedule for when they can go into work. So they can only go in for a few hours every few days, but then like the people who are there is also going to be rotating to try to limit the sickness like spreading within the workplace. And so it might have to be some imaginative things like that where, okay, we're not all meeting at one time. We just, some people can come on some days, some people on another. Because, yeah, in addition to wanting to protect the at-risk population, it's also wanting to help our healthcare system so that it's not unmanageable for them and not overwhelming. Dr. Cook had a question.
I just wanted to know if there's any data yet about what's the rate of mutation in this virus and how does that play into predictions?
That I do not know. I do know, so this is one of the larger positive sense RNA viruses. And so I don't know. I'm sorry. Yes.
Back to your slide that shows the various countries like Iran and Singapore was shown. Yes, now these countries have different populations.
Yeah, I'm sorry, what?
These countries have different number of people living there, and these are absolute numbers of cases, not per capita or per 100,000. So based on the population size, how would you compare the rise in the United States to other number of cases, let's say in Italy or Singapore?
That's an excellent point. I did not calculate that for you. The disease rate is, I don't even know that CDC is really reporting that information in terms of our rate per population right now. Of course, we could do the math. The U.S. population is about 327 million people, give or take. And so we could do that math and figure out what our case rate is. But I unfortunately didn't do that to prepare for this seminar. I'm sorry. But you're right. I mean, that's going to have impacts on the way that it overwhelms those healthcare networks and things like that. But I think the point I was really trying to make is that if you don't take this seriously, it can have really serious impacts on the number of cases you should expect to see. Yes, it would be better if we had the rate. Absolutely.
I might be wrong on this, but I also think that it would be helpful to know the age of the number of the elderly age, because isn't it that one of the big reasons Italy was hit so hard because they do have a larger percentage of the at-risk population, and so that could significantly affect it too.
So what Dr. Cacho said is that Japan tends to have more even than Italy. So, but you see that what Japan has done has probably saved lots of life with what they've done. Okay, we have a question here with Melissa.
I was just wondering, so what do you think about, an email just came out from the president, and You're saying that students are going to be able to kind of elect if they want to do online classes, but not the School of Medicine. We'll still be in session and everything. And so, what do you think about these large groups being together right now? I mean, are we like a large group of just germs and carrying it all around?
I know my group in Heem, we all passed around something in Heem, and so there was only 9 of us in that room, and I think all but 2 of them got sick. So even in the small groups, we can easily pass it around.
We're not decision makers. We just wanted to provide the most up-to-date information for those who do make the decision. So my understanding is they're
I'm just worried about us being in high traffic areas.
Yeah.
You know what I mean? Like I go to the grocery store or, any kind of high traffic area. I mean, am I going to pick up something there and then
Just want
go?
to walk around more with Lysol and wipe your desktop down more. And
keep 6 feet away from people.
Yes.
So she and I are too close together right now, for example. Most of you are too close together right now. And the reason for that is because we know those respiratory droplets can travel 3 feet. So 6 feet is like a good, just to be safe, barrier.
I'll point out a couple of things that came in online, but before I read them, I will mention, as was just stated, there was an email communication during this presentation from the Office of the President that gave the current university stance in handling of the situation. And so that email answers some of these questions to the point of what we're doing, why we're doing it. So I'll ask them, but your stance, I'm pretty sure, will be that you're not the leadership, you're not making those decisions. But I'll go ahead and read them since they were asked. Besides the hotline for students, what other steps is the university taking? Other schools in Georgia have closed already. What is Mercer's plan for protecting our students? And again, I'll mention that email was sent to anyone with a Mercer email address.
Oh, I didn't realize that was a question for us. I thought you were reading the email.
That was a question for you, that question.
Oh, okay.
And I'm not sure if you have an answer for it, or if you wanted to just defer to the statement from the
I have
Office
faith that
of
the
the President.
president is going to make any plans that he makes are just going to be in the best interest of the students and to protect the students and to ensure that they are happy.
And I think it's important to realize that we all approach this situation from different perspectives. As people that are concerned about infectious disease and public health, we have different priorities than an economist, for example. I mean, on a certain level, if you survive coronavirus but starve to death because you ran out of money, I mean, both things are important, is what I'm trying to say. And so I don't know that there's one circumstance that overrides the others. And so I think that our decision makers are making the very best decision they can based on the information they have.
Right, which I think would apply to this next one, which was, why is the Mercer making campus not shutting down immediately to prevent transmission of the virus? Prevention is key and the best approach to handling this outbreak.
They're not wrong. However, I mean, I'm not saying that Mercer's doing the wrong thing. What I'm saying, though, I mean, like, you're right. Science and what we presented today has shown the power of social distancing. However, we haven't had any cases in Macon yet. To my knowledge, I mean, we've been here for an hour and things are updating all the time, but that may be part of their decision matrix.
And the last point wasn't related to that, and it dealt more with, I guess, the social distancing and those at-risk patients. It was, how about people over 60 going over to a friend's house?
I would not do it. I'm really sorry, but I would not do it. There are things you can do over the phone or over other methods, and that is honestly where I would focus my effort if I were in that population. I know it's going to be really hard. Nobody wants to do this, least of all me, because I'll be there with a 9 and 10-year-old. So, and I love them, but all right.
You matched them. We have a question in Savannah.
Okay.
So I guess it has 2 facets to this question. We aren't seeing comparable numbers come out of Africa. And then secondly, you said that when the summer comes, which is soon in Savannah, we won't see a decline in cases?
There's no evidence to suggest that we wouldn't see a decline based on the fact that we are seeing it circulate in the Southern Hemisphere right now. That is the main reason why I would say that. But of course, we're going to have to see how this plays out because we're not in true summer right now in the Southern Hemisphere. We're in their fall. So there may be an issue with the heat, but we'll just have to see. When it comes to, you wanted to talk about what's going on in Africa, you're right. There aren't a lot of reports there so far.
I think this has more to do with their public health infrastructure than them having cases. The chances are that the virus is spreading, they're just not looking for it. Just like we are fairly confident that the virus is spreading here, but we're not looking for it as robustly as we might like. Okay, we've got a question locally with Dr. Iqbal.
Oh, is it my turn? Okay. When I held this mic, I said what action. but I do have a question. I was gonna say, so I wasn't updating on this, but in Georgia, has there been a case of community-acquired infection? Okay.
Yeah, so remember when we looked at the Georgia situation here, we had these weird cases out in areas that don't have anything to do with Atlanta. We have
like no exposure to a traveler.
Yeah. So I can't remember the exact counties, but I know it was this one and one other where these two individuals happened to go to the same church event, and then came up positive independently in their own state or in their own counties. And that was from yesterday's press conference. Okay, yes.
There is one other question that came in online, and I'll remind the people online in Savannah that presenters here have not had a chance to read the communication from the Office of the President, so they are operating the blind on that. But they call out one specific bullet point in the communication, that is, the School of Medicine will continue normal operations, recognizing the important role that its students, faculty, and staff play as part of our healthcare delivery system. That was in the communication, and here's the question. All right. Thoughts on the dichotomy between the hospital, Navicent, restricting student access starting today, and the school saying medical schools should continue as they play a part in our healthcare delivery systems?
So a couple things to unpack here. First is that Navicent is where the cases are going to be. When the cases come in, that's where they're going to be. So the reason I mean, I'm not a decision maker once again, but I would suspect that the reason why they're restricting student access there is because it's to protect you, honestly. And the second thing about why maybe the school is staying open is something that we discussed in my small group today, which is, you know, just like everybody comes with different perspectives, many of you are here on loans, and loans that weren't necessarily tied to tuition, but were tied to things like living expenses. And those expenses don't go away just because your school closes or goes to online format. You still need to take the step 1 exam or the step 2 exam or wherever you are in your progression. And so there's an issue with making sure that for students we can serve, that we do serve. And so I think I can't speak to what is inside the minds of those individuals, but I can understand where they're coming from.
I just got one question. And I got a little concerned there because you were saying that the ones that's over 60, you know, not to be around their family. I am way over 60.
Yes, ma'am.
And the thing of it is, I be around my family a lot. So are you saying that I need to stay from around my family? I mean, that would sound confusing to me.
So I understand that there are going to be certain family constructs where this is not possible. But if you have the opportunity to limit your interaction, it might be in your best interest. Everybody is going to have to assess their own risk and make decisions based on what's best for them. But for my father-in-law, for example, we decided to cancel our visit, for example. But that's a decision that each family will have to make. Thank you.
Thank you. I'm also over 65, and I see the emotion when you talk about this, and I trust your expertise. I just wonder exactly what we can do if we're over 65, and how long you think this might be to stay in the home, isolate, something like that. Is this a couple months? I know you can't predict, but
yeah,
yes, perhaps.
I understand. I'll do my best. No, I can appreciate, and obviously I maybe inappropriately displayed some emotion about this too, but yeah, I mean, if you're over 65, the best thing you can do is to limit your interaction with large groups.
to limit high traffic areas, that sort of thing. Again, that's going to be an individual risk assessment that you have to do. But I mean, as far as, you know, and something that I know this school has done a really good job of is if you are feeling sick, you know, stay home and we will figure out a way to, or the guidance that I've seen is, you know, figuring out a way to help you telework if it's possible, or you know, liberal leave policies or that sort of thing. That's what's been coming from HR. And so I'm encouraged by that, and I'm seeing that in other employers too. And so it's my hope that everybody in this recognizes that it's inconvenient, but it's inconvenient for a good reason. And that is because, you know, we want to take care of folks like you that are the folks we're most worried about. Oh, I have no idea. But what we've seen in China so far was this started in December and it's still raging. And it's been 3 months. So depending on when we start implementing some of these more aggressive social distancing measures, that will perhaps shorten the duration of this event for us. As of right now, and again, I've been in here with you, so I have not seen the latest news report. My understanding is we're not doing those sorts of things aggressively yet. I mean, we are seeing closures of sporting events and things like that, and that's really great on an altruistic level from these companies, schools, whatever. But we might need more, is what I'm saying. So, right. I think if there are no other questions, I want to thank all of you for coming.
Do you have any updates, Dr. Silver?
Of course.
This came out.
One sec, Dr. Sumner's getting
And the university met till late last night trying to figure out a policy, and that doesn't always apply to us. As I said to some of you this morning, that because we have graduation requirements in our clinical students. The AAMC stance is that third and fourth year students will continue in their clinical rotations with the exception of the ICU and ER. What we've been doing this morning is looking at requirements, and we've identified students that have not met their requirements, who are seniors, who have to do it. So we're figuring out alternatives to that right now. Third years will continue in their rotations unless they're sick, and if you're sick, you do not need to be at work. But they will not be in the ER primarily because of exposure, or the OR because of lack of mask. But other than that, we're going to proceed as is, using, you know, extreme precautions. The hospitals have policies so that in some of the ICUs, they're allowing only the caretaker to enter the room, like the resident or the attending, only one person. So the student can observe, but they cannot participate in that. If they have respiratory isolation, they're trying to minimize the risk. The AAMC, and I agree, is you're the health professionals, and we can't leave sick people. But you need to take care of yourself and use precautions. First and second years is what we're working on right now. That's where I was. We're going to say that starting Monday, we hope we can get our Zoom together, that small groups can be Zoomed if you want to. The professors will be in those rooms. They will be leading the groups. If you feel like you're safe to come to class, come to your small benefit in that. If you are ill, do not come. If you're immunocompromised, do not come. If you feel better here and want to stay here, the faculty will be here. Large groups will be Zoomed, recorded, or online. We're working through that to make sure. So yeah, I noticed one class got a mandatory group on Tuesday. That is mandatory, but you'll be able to Zoom or look at it on camera. So we're working through those. Most important, you need to take care of yourself. We will have, I've been carrying my email around. I've written it 40 times because every hour it changes. But it should come out this afternoon. Please check your emails over the weekend. If you're not going to be here, we're going to set up one person for everybody in the whole school to email to. And right now, when I just left, I think it's Linda Grant who will get it to the right person. But don't take them hardcore. We're still working through that. We're making sure that the fourth years, first and foremost, are ready for graduation. The third years don't miss anything that would slow their graduation. And the second years stay well and get out of here and study with, you know, minimal contact. And the first year, we're going to take care of y'all too. So, but anyway, this is, I think the president's about to declare a national emergency, and that's supposed to release funds. It's been an hourly change. Now, got a call from the chair just a minute ago. Somebody had called him and said that Navasset had asked for our students to be out for 60 days. That is not true. They said they're going to reassess their policy on ER and OR in 60 days. That's all they said. So we want to make sure that you get an opportunity. You don't see a pandemic that often. I don't want you to get sick. I want you to see how the system works. We're trying to protect you while meeting educational requirements. But if you are concerned about it, we're going to try to figure out every way to distance learn. And your safety is our very top priority, and that of the faculty as well. But we'll be here next week. So please don't hesitate to reach out if you have a question. Is that answering? And I would, we're going to send an email out before the close of business, for that maybe midnight tonight. But we want it to be right. We don't want you to hear 40 different versions. Okay? So thank you.
Okay, and thank you very much, Dr. Sumner. Just to send you guys off, just remember, this is historic. These are historic times, and you're going to remember what happens here, and there are going to be small bits of heroism in everyday life. So try to see those, even amongst your anxiety, and we'll get through this. So thank you, guys. Thank you to everybody on Zoom.